So, sir, it's 3, 2, 1. We are live to the audience. Over to you, Dr. Hardik.
Thank you. Thank you. Very good evening to everyone. Myself, Dr. Hardik from Eris Life Science Medical Affairs team. And it's my immense pleasure to welcome you all to today's national webinar organized by Blue Team. Our session today focuses on the topic of critical clinical relevance, which is what should be the fasting glucose target, focus on the basal insulin. As we know, optimizing fasting plasma glucose is the foundational to achieving the overall glycemic control, and basal insulin plays a pivotal role in this strategy. However, defining the right target remains a subject on ongoing discussion, especially in the context of patient-centric and evidence-based care. So this webinar aims to bring the clarity on setting the appropriate fasting glucose goals and understanding how to individualize the basal insulin therapy for the better outcome. So we are honored to have with us the leading experts who will share their insights, practical approaches, and the latest updates in this area. We thank you all for joining us with this webinar and look forward to engaging with the informative session. Let's begin. I would like to invite our moderator for today's session, Dr. Sanjiv Shah, sir, who is formerly endocrinologist at Nana Max Super Specialty Hospital, Mumbai, academic clinician in the private practice, 43 years in the Mumbai, clinical pharmacology at KEM Hospital, and the researcher in the global trials in the diabetes, 50 original research clinical studies, and the 20 book chapters. I would like to invite our speaker member from today's session, Dr. Arundhati Dasgupta ma'am, who is a director and the consultant endocrinologist at Rudrashka Super Specialty Care at Siliguri. She has achieved A.B. Gandhi Award in 2012 for the best thesis, then Diabetes Awareness Initiative Award in 2018, Young Achiever Award in NCCD at 2022, ESI President Appreciation Award 2022, RSSDI Innovation Award 2022, Icon of Endocrinology Award 2024, and course coordinator with PHFI and several other national and regional training programs, several national and international publications by the Dr. Arundhati ma'am. I would like to invite our another speaker member from today's session, Dr. Sandeep Julkar sir, who is currently consultant endocrinologist at Radiance, the Hormone Health Clinic and CHL Hospital, Indore. Reviewer for the Journals of Diabetes and Metabolic Disorder, European Journal of Internal Medicine, awards and recognition speaker at the national and the international forums, lead trainee at the 2017 program for the physician trained by the government of Madhya Pradesh. I would like to invite Dr. P.K. Jabbar sir, who is a diplomat of National Board, MD from MD in the General Medicine, DM Endocrinology, diplomat at National Board Endocrinology, professor and head of Department of Endocrinology, Medical College Trivandrum, and director and CEO of Indian Institute of Diabetes. Once again, I welcome you all in this session.
Thank you, Hardik. So let's start the scientific discussion. A simple question on fasting glucose. When it comes to an insulin initiation, any kind of insulin, patient has significant hyperglycemia, predominantly fasting hyperglycemia. And as all of us know that fix the fasting first is a dictum in managing with insulin. So a simple question to start the journey of discussion on fasting blood glucose. What regulates the fasting blood glucose in healthy person? Which goes wrong? And so in a diabetic patient, fasting goes high. 126 is a cutoff limit. But when we initiate insulin, it goes as high as 200. So let's understand what keeps fasting below a diabetic or non-diabetic pre-diabetic limit, which is less than 100, So Dr. Arundhati would start with what regulates fasting blood glucose in healthy person, a simple physiological concept. Dr. Arundhati, please.
Right, so thank you so much for that question. So basically, if you have to understand about the fasting plasma glucose, it's basically regulated by an interplay of hormonal, hepatic, and peripheral mechanisms, which basically maintains the glucose homeostasis. So if you talk about the main regulators, if you talk about the hormonal regulators, number one is, of course, insulin, which decreases the fasting plasma glucose. And the basic role is to suppress the hepatic glucose production. And it's basically, though in the fasting state, the insulin levels are generally low, but there is still a tonic inhibition of the hepatic glucose output, which maintains it under control. Then we have, of course, the glucagon, which is responsible for actually increasing the fasting plasma glucose by stimulating the hepatic gluconeogenesis and the glycogenolysis. So in the fasting state, it's basically the glucagon level rises to maintain the glucose availability. Then there are other hormones like, say, the cortisol, which is an enhancer of the gluconeogenesis and antagonizer of the insulin, and thereby it increases fasting plasma glucose. We also have another hormone, growth hormone, which has an action on lipolysis and hepatic glucose production. And of course, there's a role of the catecholamines also, the epinephrine, the norepinephrine, which have a role in stimulation of the glycogenolysis and the gluconeogenesis. Now, if we talk about the hepatic glucose output, which is basically responsible for the fasting, and the glycogenolysis, which is breaking down the glycogen, and the gluconeogenesis, which is generating the glucose from the the non-carbohydrate sources. So that is whatever is regulating that is mainly controlling the fasting plasma glucose. There are other factors which affect, like, say, the neural regulation. You could have the autonomic nervous system, which could have a role. We've also understood about the role of incretins, GLP-1 and GIP, though they are more active postprandially, but they still do have background effects in the insulin glucagon balance, and thereby the state of affairs in the fasting state. So this in a gist is basically are basically the factors which regulate the fasting glucose in a person in health.
Thank you, Dr. Arundhati, for clarifying what's important. And let's examine the exactly opposite thing. So let's invite Dr. Sandeep. There are certain mechanisms which operate when a multiple oral agent. So there are different agents, basal, everything has failed. About 3 drug, 4 drug, 5 drug, and a patient requires insulin. Sandeep, would you explain about how it goes high?
Yeah, good evening, everybody, and thank you for the question, sir. So my answer would stem from what Dr. Arundhati just said. So we are talking of a secondary OHA failure when your tablets are not working. There is some beta cell dysfunction, beta cell loss. And we know that fasting hypoglycemia is due to the gluconeogenesis. So there was an imbalance of the counter-regulatory hormones as stated by Dr. Arundhati. There is insulin deficiency, which insulin we know regulates the hepatic gluconeogenesis. There is paracrine effect of the beta cells on the alpha cells. So there is glucagon dysregulation, rise in glucagon leading to fasting hyperglycemia. And the OHAs obviously do not do their job because there is deficiency of insulin. That is when what happens is there is increase in fasting blood sugars, and of course then the postprandial blood sugars also rise. So that is how basically the OHAs land up being what is known as the secondary OHA failure.
Sandeep, little extension, we are in era of GLP-1 RA, and we have a potent GLP-1 RA which are entering the market. And our listeners might have a feeling that they are so powerful on weight. Do you think that they can replace insulin in people who have significant beta cell failure?
So
it would vary from patient to patient.
Yeah.
But could you highlight what is the percentage of people who may still not respond to GLP-1 RA and the reasons?
Yeah. So I feel that we cannot say that GLP-1 RAs will replace insulin, because when you have, so one subset of patients like osmotic features will definitely require insulin. In others who are on insulin and our experience with the latest GLP-1, GIP agonist is that the insulin doses go down and somebody on an MSI will come only on basal and do away with insulin altogether when there is significant weight loss. So the corollary is for physicians, those attending, when somebody underwent a bariatric surgery, the second, third day onwards, suddenly the insulin requirement went away, and the cause was found to be the increase in GLP-1 and reduction in ghrelin. What happens with when you give GLP in a significant amount? What happens is when you give GLP-1 agonists, what you're doing is a glucose-mediated insulin release. There is decrease in gastric emptying, there is weight loss. That may take away when we stated that you have to start early insulinization. Now with the advent of GLP-1, GIP with SGLT2 inhibitors, probably we may defer the initiation of insulin and do away with insulin in some of our patients. And what percentage of those patients? I think at least 40% of patients we may not give, say, a basal insulin start, and we want to give a GLP-1, GIP, GLP-1 alone, or a insulin, basal insulin plus GLP-1, a premix. That combination is also available. So I'm sure there'll be patients now. Yes. Yes, sir.
So you are suggesting that it should be first injectable therapy should be thought about before considering insulin.
So considering the HbA1c weight paradox, I think yes. The GLP-1 field with the GLP-1 GIP and with the tri-agonist, since I have some experience with the tri-agonist as well, it'll be phenomenal. What we are looking forward is really, really bright future for GLP-1s and all the incretin mimetic drugs.
Thank you, Dr. Sandeep. Let's move forward. Let's examine what is associated with cardiovascular complication in diabetic people. We know that all three are important: HbA1c, PPG, and fasting glucose. This is a prospectively designed Korean population of about 12 lakhs people, and they looked at on long-term follow-up in diabetic as well as in non-diabetic people. If fasting glucose was higher, cardiovascular mortality, stroke incidence, and cardiovascular disease was much higher. This is what was distinctly seen for different cardiovascular endpoint like atherosclerotic vascular disease, ischemic heart, MI, stroke, thrombotic stroke. Most of the complications increased in association with the increase in a fasting higher than 125. So in conclusion, both low glucose and impaired fasting glucose should be considered as predictor. Low glucose is associated with multiple morbidity, sick patient, and those who have this is kind of a J-shaped curve. The reasons for low glucose is different than in non-diabetic people compared to hyperglycemia. But in diabetic people also, we know that hypoglycemia has an association with higher cardiovascular risk. So we would ask Professor Jabbar, what is the relationship of fasting and vascular disease in your opinion, based on this is another study which is meta-analysis of 102 prospective studies. Using this particular kind of meta-analysis, let's take opinion of Dr. Jabbar.
Thank you very much. Thank you so much, Dr. Sanjay and team. First of all, let me thank the organizers of this meeting and pharmaceutical company, the Eris Pharma, for the wonderful platform. And of course, so there are a lot of joys in the field of diabetologists are sharing the chair with me. The question is very straightforward. When I finished my DM, say that time, so just before finishing my DM, we got an important paper by American Diabetic Association. The diagnostic criteria has changed. Before 1997, it was 140 that came down to 126. So what was the basis for this reduction of threshold of blood sugar? So that is directly linking if the fasting blood sugar goes more than 126, it was clearly showed the microvascular disease escalation. And when you discuss about postprandial hyperglycemia, it's a very, very important risk factor for vascular disease, especially macrovascular disease, as evidenced by Paris prospective study, Chicago heart study, Honolulu study, and all. So it was very clearly said, macrovascular disease is clearly linking with postprandial hyperglycemia. Of late, if you read this article, emerging risk factors for vascular disease, it was published in Lancet 2010. It showed, they have analyzed a lot of papers and clearly showed the fasting blood sugar is also a very important contributor for vascular disease. So we can't neglect. But mind you, correcting postprandial sometimes very tough, and correcting fasting is not that difficult. You know why? Because we have a beautiful molecule, long-acting molecule. If you remember the discussion by Arundhati, she clearly said the factors responsible for hyperglycemia fasting as well as postprandial. So we have beautiful molecule. So correction of fasting blood sugar is very, very important, unlike the previous thought process. So for that, we should have very honest and very sincere effort to reduce fasting blood sugar also. Yet another interesting phenomenon is probably little deviating from your question. The glycosylated hemoglobin is a reflection of fasting as well as postprandial. In Monier study, UK population, of course, the postprandial is dominating if the glycosylated hemoglobin is low centile, and if it exceeds more than 9 or 9.5, fasting is important and important contribution. Mind you, my dear friends, in Indian population, as discussed by Wang et al., they showed both these blood sugar fasting as well as postprandial is very significant. So to conclude, always we should maintain very good fasting blood sugar also, not only postprandial. That's an important message I want to give, and I'm signing off for the time being. Over to Sanjay. Thank you.
Thank you, Dr. Jabbar. Let's take the fourth question. When we have a patient sitting in front of us and has a prandial hyperglycemia, we think of selecting a drug which are focused on a prandial. Mechanisms of prandial hyperglycemia are different. Mechanism for fasting is different. We have seen that. But if the fasting is high and you want to treat with or select an oral agent, we have to think differently. And I have listed the drugs on both the side which address prandial and fasting. So we want a comment from Dr. Arundhati about the ability of this basal drugs, which are all predominantly acting on basal. Some may be working on both the sides. So your comments on basal drugs, which address a fasting glucose.
Right, sir. So when you're talking about drugs which are basically addressing the fasting glucose, and as you have very clearly stated in this slide, we talk about metformin, we're talking about pioglitazone, the insulin sensitizers, and having discussed why fasting hyperglycemia occurs, an insulin sensitizer is expected and it does act on the fasting glucose. SGLT2 inhibitors also we've seen, to act on the fasting glucose and bring down the levels. Sulfonylurea, yes, we've used sulfonylurea. We do use sulfonylurea as a mode to bring down the fasting glucose. But basically, since we're focusing on basal insulin more out here, I think primarily, if you're talking about something which is specifically controlling the fasting more than the PP, I think we've been using basal insulin for a very long time now. So basal insulin, which started off with NPH and has transcended, across the years to develop where we are standing today. And large U300, U300 or degludec and the others, the basal and the flat and the flatter profiles. So I think with the use of basal insulin, we have actually achieved significant control of fasting plasma glucose. Having said that, if someone does not require, is not in a state where the person is requiring an insulin, we, in the initial stages of diabetes, we very well can control them with metformin and pioglitazone. I think we are doing it right, left, and center, and SGLT2 inhibitors. Sulfonylurea per se as a controlling agent for fasting hyperglycemia, it's not per se. It's basically because of its mechanism of action. But yes, it can also be used as one of the agents for hyperglycemia. So I think
Thank you,
we
doctor.
focus on basal insulin more. So yeah.
If we see the potency of the drugs on the first two drugs versus three drugs on the right, our basal drug seems to be far more powerful than the prandial drug on the left. We know that most insulin naive patients are initiated with basal insulin analog, usually glargine all over the world. So, simple question for Dr. Sandeep. Glargine, we have spoken so many times. I have a slide which shows that glargine U100 and pH U300 duration of action and action profile. So, do you think the duration is relevant? Relevant in which way? And your comment in relation to kind of a little peak or kind of a flat action. We received glargine long back when only NPH was a basal insulin, and we thought we received really a flat action insulin. So subtle differences between all three of them.
Yeah, so I must thank you for bringing out this slide because it really compares all the ultra long acting insulins and the one which we used earlier. So when I just entered my DM in 2000, and then glargine came into the market, and it was one drug which made a lot of noise, and it has really transformed how we manage diabetes, and the concept of fixing fasting first really caught on, and that is why most of our patients really took on to insulin, because when we used to start them on twice premixes, there used to be a hesitation. Here they used to say, okay, we just said, okay, start once, you bring down the fasting, the osmotic features used to go away, and it really helped. Glargine was the first relatively, as you stay almost flat. So it is almost peakless, although when you do CGM studies, you find that there may be a slight peak, but then mostly, but there is a word of caution. Whatever insulin you use, it is how you use it is more important. As we were speaking before the webinar, Dr. Sanjiv, that we wanted to be a more of a practical webinar rather than having a lot of theory in it. Whether you use glargine U100, 300, degludec, how you use it, how you explain it to the patient, how you explain the CGM, the self blood glucose monitoring, that will determine the success of your glycemic goal rather than using a fancy insulin. Glargine is a wonderful insulin. Even now, almost 70% of my patients in my OPD get glargine rather than other long-acting ones. It works. Its initiation, so it is acidic. When you inject it, the pH makes it into a depot where it is gradually released. Its onset of action is 1.5 to 2 hours. It works almost 24 hours. You start with 0.2 units, but yes, there was a question on the variability. We now have ways and means of measuring glycemic variability, so we talk more about it. The CGMS studies and all those time in range, time above, below range, all have been compared to glargine, and glargine stands tall. The glycemic benefit of glargine is similar to the ultra long acting ones, except for the time, maybe the glycemic variability. A word of caution, the variability of its action also depends on lipohypertrophy, which has to be explained. So once we have to explain to the physician that changing the site is important. There is lipohypertrophy that will affect the duration of action, that will affect the glycemic variability. So everything has to be taken into account. So how you use that insulin is more important than what insulin you use. Sir.
Thank you, Dr. Sandeep. for bringing out and clarifying. Insulin works, potency is similar for all the three insulin in terms of degree of lowering of blood glucose. Now, when the insulin is initiated, 10 unit as a arbitrarily perfect number is selected far more frequently rather than a 0.2 unit per kg body weight, where in an overweight patient, the dose could go as high as 16 and 18. Now, I always felt that in every patient, is it right to start with a 10 units? Far more frequently, I start with a different dose, and that has an impact on how you achieve the control. So we are going to ask Dr. Jabbar, who is a professor of endocrinology teaching so many postgraduate students. Dr. Jabbar, this is kind of a paper which was done on healthcare professional. 75% of the physicians said they have discussed, but very small number remembered. So this is obviously a story on all the diseases, any drug. People have lesser knowledge. They do not recall when they reach home. And large number may not know that this medicine requires a titration. For OAD, we prescribe a dose and that's final. So there is a time, there are all the stories around titration. So I want you to address initial dose, titration of glargine, how to achieve fasting glucose, and your recommendation.
Thank you, Dr. Sanjiv ji. It's a beautiful question. See, initial discussion, see, as per the theory or textbooks, you can use 0.2 or 0.3, whatever units per kg per day. But in practice, as you have clearly said, very perfectly said, see, usual starting dose is 10 units. And the merit of this glargine is a very long acting. Probably you'll get little more than 24 hours. So once daily, that's more than enough. And if you go for 10 units of insulin, what I'm practicing now in my clinical or clinic or in my institute, I will increase the dose of insulin every third or fourth day. Probably if the blood sugar is very high, I will change my strategy. But this is very slow. What is the urgency there? Urgency is not there for controlling diabetes mellitus. With after introducing this glargine somewhere in early 2000s, the prevalence or incidence of diabetic ketoacidosis has come down drastically because a very long-acting drug, you will have little insulin in the portal system, whereby the lipolysis is reduced and quenched. So ultimately, the reduction of diabetic ketosis was there. So there is no hurry. Just give small dose of insulin. 10 units of insulin, that's more than enough in most of the situation. Of course, we are discussing about type 2 diabetes mellitus, pediatric patient, small frame patients, slightly different approach you can have. And after that, you just look into the preprandial blood sugar, and depending upon the blood sugar, if you have good setup like self-monitoring of blood glucose, of course in a high-five situation you can go for CGMS system. You can modify the dosage of glargine. It's very simple, and trial and error method, that's the best method which you can start and use in your clinical practice. That would be the good take-home message. Always after correcting fasting, as my friends were discussing, fix fasting first, F. After that, you should look into the postprandial blood sugar. For that, you may have to go for other insulins also. That's my usual practice, more or less par with the recommendation by professional forum. Over, sir. You can take.
Thank you, Professor Jabbar. Arundhati, let's take this question forward. There are, in the literature, 3 right ways to initiate insulin. And then there are success or there are failure. I would say 4th way is each individual physician has his own adapted method. If we examine this particular paper, which is an Asia-based study, Dr. Manoj Chadda had been part of Indian investigator here. And these are the people, HbA1c at the time of initiation was 10.5, highest in Southeast Asia. And the duration of diabetes was 9.3, plus minus 6.5 years. This is how was an HbA1c in 3 different basal insulin, glargine, NPH, and detamers, close to 10. If you see the fasting glucose, which is our subject today, is anywhere between 210 to 226 in 3 different groups. My question is, after 6 months of basal insulin, whichever insulin used, A1C reduced to 7.7 from 10.1, only 1/3 reached target 7, and 210 reached to 129. Similar number, 1/3 achieved less than 110. So I have a question for you. There is another paper also put up. What do we learn from predictors of failure, that we are going to fail with a basal insulin in 2/3 of the patient? The best of the best paper had 50% success. Matthew Riddle and their papers, who had 50%. Many papers had 40% success. Meta-analysis will tell you different. So what are the predictors of success or a predictor of failure with only basal, which results into intensification? Based on your experience, based on your reading, what would you suggest?
So I think, sir, this paper that you have shown, it is one of the papers that has looked into what are the predictors. And as you can see, this paper is saying age, it is saying, a longer duration of diabetes is one of the predictors of failure, or a higher body weight is one of the predictors of failure, and a higher HbA1c is a predictor of failure. But these are there, definitely they are there. We all know the longer the diabetes has been, the poorer the control has been, the chances of achieving the target is lesser. But I think where we started off, where Dr. Julka was saying that in my clinical practice, I think the most important determinant of failure is when the patient is not explained properly as to what has to be done after initiating. I think that is the most of the patients whom we see, we ask them to send us an SMBG, say they're sending us via WhatsApp, and we see that, things are not reaching where they should. We've asked them to up titrate. They're not, they're doing it, but things are not there. So we have to call them back. Most of the time, in my practice, I would say it is about the insulin technique. It is about the method of titration. It is about the food that is being consumed. It is about the thought that if I'm taking insulin, that I can have anything. It is about the comprehensive explanation of what has to be done and why, what has been initiated, what are we looking at, what are the factors. Having said that, if we set everything correctly, we've explain to the patient the diet is all right, the technique is all right, the up titration is good, the patient has been taken into the loop for up titration, and yet if we are not reaching our target, then of course we'll need to take a look at, these are the other factors which might, I will not say we'll not reach target. Maybe the time to reach target will be delayed. I think all of us know from our practice, even if a person has a very high HbA1c, if you're going about diligently in your, up titration of your basal insulin, you will reach your fasting target. And, unless there are hypoglycemias at night, or there are other factors which are hampering the somogi, we need to look into those factors. Shorter duration of diabetes, as has been mentioned, is a predictor of success. Yes, patients who have new onset diabetes, they come in with catabolic features, and we are putting them on insulin. Their response is definitely earlier than patients who've been on OADs and failure, and then we've put them on basal insulin. Definitely. And higher BMI for reasons understood, of course. So these are there, sir. But I'll again and again emphasize that if we explain things properly to our patients, most of the time we reach goals. Though these studies, significant numbers do not reach goals. But I think these are also patients who are not monitored or not followed closely. We're just looking at numbers here. We're not looking at individual, what has happened. So that is also an important area in my practice, I would say, which hampers the control of the fasting with the basal insulin.
Thank you, Dr. Arundhati. You highlighted very well. Ending with Dr. Sandeep on the same subject. Sandeep, this was a trial when the glargine was launched, treat to target. This is 24-week parallel initiated in comparison with bedtime NPH versus bedtime glargine. And this is what the graph looked like. Fasting glucose 200 in both the groups, more or less similar in at the end of 24 weeks. HbA1c is similar, glargine and NPH. If you see the glargine and NPH 117 versus 120, HbA1c exactly identical. Both the drugs achieved, and the conclusion was like this, that how do you compare? Now I have three questions for you. NPH isolated is not used as a basal in our country. It was extensively used in USA. But premixed is used by many people, human premixed, or there is co-formulation premixed, where 30% is meal-related insulin, which reduces the basal component automatically. So how do you see premixed versus glargine as a basal insulin and our success and the titration?
So there is nothing wrong with using a premix twice. I must make it clear because I use it myself at times when I want to bring down the blood sugars. My approach is using basal insulin. The idea of considering a premixed as a basal is flawed because you have to have, if you want to control the fasting, you have to have that much longer duration of action. So I feel that basal insulin, and once you've decided the patient requires insulin, it is usually when you're nearing your secondary OHA failure. And people who start basal insulin know very well that they will require a basal plus, and eventually they will go on to 4 times insulin. So I feel that you cannot compare the two. If you want to start a basal insulin, it has to be glargine. But if you want a postprandial control, and for example, somebody having a fasting of 150 and the post meals climbing beyond 250 or 300, and you know that your basal insulin, bedtime insulin, daytime sulfonylurea is not going to suffice, probably you would want to use premix insulin twice. For me, I think starting insulin, it is best to start a basal insulin in the form of glargine. So that is how I do it, and maybe add a prandial insulin. I hope it answers the question.
Yeah, thank you, Dr. Sandeep.
Thank you.
So now a simple question which Dr. Jabbar has answered in relation to titration. So we would skip to the next question in relation fasting plasma glucose titration target. I found this paper experts. This is Michael Nock is a third author, and a group in Germany did a meta-analysis. 43 trials on a basal insulin, 17,000 patients, and they looked at only fasting plasma glucose. And that's how, based on this paper, this title of the whole CME webinar. And so this was very extremely important. They divided patients who were achieved fasting less than 90, fasting between 90 and 100, and fasting more than 101. They called it titration target number 1 for below 90, target 90 to 100, target 2, and target 3. I will put it 1 as a very strict target and a 3 as a slightly relaxed target. All of you focus on all three. All of you are going to get one question, and we would have a concluding remarks also second time from Professor Jabbar. So this is what is glargine U300. This has practically not NPH based data. Glargine U300, glargine U300, detemer, degludec, little data on peglispro, which is not in market. All right, so we would put it relaxed target fasting more than 110. These are the papers on the left. This is kind of a data. Titration target number 3. And I have a question for Arundhati. What percentage of patients achieves PPG control and HbA1c control if their fasting is at 110, 120?
I think, sir, yeah.
Are we going to get people at a right target? Whether we should go to 100 or we should go to 90? There are many trials of 90 as a target. So let's people learn that 110 to 120 can get A1C or not, PPG or not.
So,
If you want to see, I am going to show you this particular also. This is your only opinion on the same treat to titration target.
firstly, sir, regarding these three groups, 90, 90 to 100, 110 to 30, I think we'll all decide our target based on that particular individual. We are not going to set a target of 90 for every individual in whom we're targeting the fasting. Definitely not an elderly with comorbidities, somebody in whom hypoglycemia will be a risk with CKD. We'll be a little lenient there. So having said that, so maybe I'll keep my fasting target at 110 to 130 there. But if it's a young individual, somebody who's planning pregnancy later on, who has no comorbidities, there definitely I would want to target a level of maybe 90 or 90 to 100 to 110. Having said that, this paper did tell us that, if you're titrating it well and you're bringing it under control, even without hypoglycemia, you are achieving good control. But are you going to achieve HbA1c target only with fasting control? No. In most of the cases, you are not, because fixing fasting first is fine, but it's not always going to fix your PP. Once you fix the fasting, you will have to take a look at the PP. So only fixing the fasting, maybe if the PP is just slightly above normal, it might bring down the PP, and thereby it might bring down the HbA1c. But if
here it is 39%, A1C less than 7.
Yes, sir. So, but having said that, I'll also ask you: would you really target an HbA1c of less or 90 for every patient? No,
No, we are not. We will conclude at the end after seeing all TT2, TT1.
So, having said that, I mean, there are studies which have said that you get your fasting under control in 60% of the patients, and yet you're not getting your HbA1c under control. But of course, if you do manage to bring that the fasting in the lower end without any hypoglycemia, without any comorbidities, without any problem, there the chances of reaching your PP goal and HbA1c goal are going to be higher than the other two brackets of testing.
In these trials, this kind of a target achieved had 47 units of insulin from naive. And if you see nocturnal hypoglycemia, second last, 42%.
That is exactly what I'm trying to say, sir.
Even at 110. But you will see also the next two groups. So let's, Sandeep, you have the best controlled patients. Titration target 1 for you. These are the papers. Bernard Zinman from 2012-13 has half a dozen publications here as a first author. And this is, do you believe that achieving below 90 could be done? This is the most stringent, most strictest the target. Which patient? In some people you will do it. And this is what is your group finding. HbA1c there was 7.2. Here it is almost 7.1. Only thing, percentage of patients are 52%. In Arundhati, what she answered was 39%. The dose is here 62 units.
I'm looking for the nocturnal hypoglycemia.
But it's only
the bottom is 17%. Much less.
So, sir, who was the author, and we should find out which country he comes from. Whenever we read a clinical trial,
Sandeep, this is a compilation of this many papers.
I don't see any Indian there.
Indian will not be.
So what I'm trying to say and trying to convey to the audience, whenever you read a clinical trial, see the baseline population, whether all of them had access to CGMSs, so to answer the question would be, I would not target less than 19 all. Which population? Yes, one with gestational diabetes, pre-gestational diabetes. Some of my type 1s will have it. Most of my patients in who are on 780G Medtronic pump will have a A1C of 6.5. But definitely the message to the audience will be, do not target 90 in majority of your population, except the ones who are pre-gestational diabetes or gestational diabetes, because you saw that nocturnal hypoglycemia, most of our population do not even do the basic self blood glucose monitoring. They will not have access to CGMS. So I think the practically a glucometer reading of anywhere around 110, 120 is good, even in young adults with type 2 diabetes. That is what I feel.
So we will come back, Sandeep, you will come back when I show you all three.
Yes.
After taking now the titration group 2, which has more than 90 and not less than 90. This is in between. There are maximum studies which are fitting into this. On the left, you see all the list of the studies. And Professor Jabbar, now you see the A1C is identical 7.2. The percentage of patients who achieved is 47, which is very, very close to what Sandeep presented. But units are much less, 62 versus 42, which is closer to what Arundhati presented. And nocturnal hypoglycemia much higher, 33%. The next two slides or three slides after you answer has all the secret. But your question is how easy or difficult it is to up titrate insulin when you get this kind of a glucose. Most physicians, your question is different as the questions are different. What do you think? When we get a 90 or 100 fasting, we stop up titrating. Many times we down titrate or patient down titrates.
That's right, sir. Now, see, we'll look into the realities. Okay. See, it's not that difficult to maintain a strict blood sugar of less than 90, especially with the advent of very good molecule for the treatment of diabetes mellitus, including glargine and other long-acting molecules. Not difficult at all. But I'm just thinking, why do you want to control blood sugar less than to a tune of less than 90? You are producing hypoglycemia. If you want to, you see what was the result in DCCT? If you want to get good control, definitely hypoglycemia will occur 100%. And see what is written here, 33% of patients develop nocturnal hypoglycemia. Don't you think it's a really upsetting figure? Really upsetting. For at any cost, probably you keep gestation diabetes mellitus apart. Otherwise, less than 90 should not. Number two, whatever you discuss, a figure centering around 100 milligrams of blood sugar, that is acceptable, easily possible, easily you can achieve without much nocturnal hypoglycemia. So these are my comments, and you look into the ADA management algorithm also. Start with a small dose of glargine and you titrate, and to get a good glycemic control around 126, not even less than 100 or less than 110. So that is very a brilliant idea of keeping the target like that. So these are my comments. Don't go for very strict control, even for a patient with the age of 40 or 45, something like that. These are all my personal and the document views. Thank you.
Thank you, Dr. Jabbar. In fact, a nocturnal was 33%, but hypoglycemia was almost 53%. We have about last 5 to 7 minutes. Let's look at all three groups together. On the left is titration TT1, 2, and 3. If you see A1C, it is identical. If you see what percentage of patients received, 52, 47, and 39. So the difference between the group was very little. Look at this particular daily dose of insulin. This is basal insulin only, 62, 42, and 47. That means if you are aiming below 100, below 90, your insulin dose is likely to go higher than 0.5 to 0.6 or 0.7. Now, this did happen, but surprising is hypoglycemia. In spite of 0.66 unit per kg body weight, hypoglycemia insulin is less. So Sandeep, Dr. Jabbar, it is a new generation insulin which is used with that kind of a target in those trials which use degludec and U300. And that's why units were higher to reduce just 10 milligram, but no extra benefit on A1C, but benefit only in reduced incidence of nocturnal hypo.
That's right.
Sir, may I ask a question? How is it that with the higher doses and more stringent control, the incidence of hypoglycemia was lesser? Also, are we really allowed to use that amount of, generally we keep our upper limit at 40. So are you using basal insulin beyond 40, sir? Are you going up to 62 or 65? I mean, you're beyond 60 in the use of basal insulin. That is interesting in this way.
Yeah, but all of us have done clinical trial. All of us are practicing also, and we are also teaching the physicians who are in practice. Now, when it comes to treating a patient, we keep that weight and the dose in mind. And as Dr. Jabbar said, it's individualization. Our target is rarely below 100. There are different papers on basal that if you go below 100, you increase the risk of hypoglycemia. But these authors have not done this study. They have done only analysis of 43 trials. And they have a trials which reflect.
How is it that the higher target group has 42% incidence of hypoglycemia?
Because they use degludec, they used U300. And if you have spoken on those insulin in the past, you know that the targets were closer to 70 milligram. If people had 90, you were supposed to up titrate the basal insulin, called as forced titration of an insulin.
That in the TT3 group, they were using NPH or the older insulins, and hence the incidence of hypoglycemia was more.
Maybe.
So they were older trials from 2000 to 2010. 2015 and 20 were a different trial, but this is compilation of all. So the message, I would rather put it that way, that if you really want that kind of a target, you have to use a different insulin like degludec or U300. At the same time, monitoring, which must have been done in clinical trial versus real world. In fact, today I was reading a paper on real world data on GLP-1 RA and a weight loss in real world. So what we see on a GLP-1 RA clinical trial weight loss, where everything is done, they were discussing all the reasons why things don't happen like a clinical trial. And we know what we do in a clinical trial. So this is ADS. So anybody in the last 3 minutes would like to comment on this? Dr. Jabbar.
No, nothing, Saras. I wanted to make a comment that, see, one of the slides you showed us, evening dose of mixture, only single. What is the reason for that? I don't accept that's a good treatment method for the treatment of type 2 diabetes mellitus. Single dose evening. Probably you will land up with hypoglycemia also, but judicious administration, definitely you can reduce the hypoglycemic episode. But by and large, that is not a good step in the management of type 2. That's only comment from my side. And again and again, my point is always go slowly. Target also you should have, as Dr. Arundhati was discussing, you should look into multiple factors, at least 7, Inusu's paper, 7 points you should discuss, and always try to maintain blood sugar between 110 to 120 or 130, not say beyond that. That's my view, sir.
Thank you, sir. Arundhati, in the previous point, one of the question you did mention that you take care of multiple things when it comes to prevent hypo. So I have a question to think for you and Sandeep. Is it a characteristic of insulin which results in hypo, or it is a patient characteristics? Patient takes a lighter dinner, patient injects extra dose, some drug is added as GLT2 inhibitor. Today I visited a physician, he increased 4 units. Patient has a decreased GFR suddenly happened. A GI side effects or a suddenly develop vomiting and diarrhea in a patient injected. There are so many other patient related reason rather than a glargine being at fault. So your comment on those, Prabhat?
So, definitely, as you said, I'll put in a third point also. It could also be the physician related, who has not explained enough, who has just written it and not explained enough to the patient. So we could have three aspects to it. It could be
Yeah,
the
you highlighted earlier.
yes, it
So
could be the
we
insulin.
can request areas that extend your services in the patient education on insulin. Extremely important point.
Absolutely. So it can be the insulin which is not in the right dose. We need to look at. Also, importantly, I think when we are looking at what is the basal doing, we also need to understand what is happening to the post-prandial, like the post-dinner. Many a times that is also causing the variation that is happening in your fasting. So that also needs to be taken into account. And as you said, so there are so many patient-related points. Technique, food, comorbidity, as you said, a dehydrate, something which is causing loose motion, dehydration, any acute impairment of the renal status, all of that can also affect. So definitely, once we are starting a patient on insulin and we are looking, so that self-monitoring is very important. Sudden rise, sudden fall, that the cause needs to be looked into. And of course, all the other aspects that we've all, discussed along-wise, those have to be taken into account because there is no one correct answer. Each person is going to be very individualized in his or her response.
Yes, Sandeep, we are in the
Sir,
last few minutes. Whatever value addition from your side.
just one value addition, sir. The statistics that we initiate insulin after 9 years and with an HbA1c of 10 is sad. Please put your patients on insulin at the appropriate time. Whatever insulin you use, you have to educate yourself. It is for the physicians. Educate yourself. Only then you will be able to. It is said the patient with diabetes who knows the longest lives the long. Who knows the most lives the longest. So impart education. Insulin doesn't matter. As Dr. Sanjiv said, it could be patient factors and doctors' factors which lead to hypoglycemia rather than using that insulin. So get yourself abreast with what is happening in the world. Get to know the newer insulins. Get to know the newer diagnostic modalities. That is all, sir. Thank you so much.
I think self-monitoring is extremely important. We should also, I now regularly write down that patient is permitted to down titrate insulin if they notice or if they record less than 90, nothing wrong, because they feel that whatever is, I also see the patient 70, 65, 55, but they don't reduce the insulin. They think that doctor has not allowed us to reduce the insulin. Yes, Sandeep.
For all the physicians who've joined, I think there are 200 and 2,400 physicians who've joined, some endocrinologists. If you feel that you spend more time, the patient comes to you, you charge him and the patient goes back, and then you have to titrate it on the phone several times, and you feel that you're not getting paid to it, please attend a seminar by Dr. Sanjiv Shah. He will tell you how to monetize it.
Sandeep, this 18th May, we ran the same program with three different younger experts. We had on that day also 2,358 physicians who joined. With that success, we repeated again in this June, a
Yeah.
month later. Only thing I changed two slides and two questions from last. Every time we repeat, I modify, but all the slides and content was curated by me. Glargine had been extremely important subject.
Yeah,
So
very
it
nice.
continues insulin journey. With this, I thank all the experts for participating in an interactive discussion.
Thank you.
Over to you, Aries team, for the final words. Aditya.
You are muted.
So, first of all, we would like to thank all the participants for joining this program. We actually clocked almost 2,500 physicians joining across the 23 states and union territories. So this must have been learningful for all those participants who joined and learned about the glargine and basal insulin. At the same time, we'd like to thank all the experts, panel members for joining today and guiding and giving their expert opinion as well as their practical clinical experience with the participants. So, Sanjiv sir, thank you very much. Sandeep sir, thank you very much, sir. Dr. Jabbar sir, thanks a lot, sir. And Arundhati ma'am, thank you for taking your time and joining us. With this,
Aditya, it looks like the popularity of our experts has broken the previous records. We
true.
never had probably this
This is
many.
the
We
first
used
time
to
that we are
hit
clocking
2,000,
2,500 dogs.
2,200, 2,100. We have reached 2,400. So
Sir,
you
I
brought
think it's
truly.
Sir, it's the rains. People are getting to stay at home because they cannot go out, so they've logged on to us. It's not us.
Possible, sir. But yes, for the first time we clocked this 2,500 number. But yes, thanks a lot for joining and making this even more learningful.
Good
With
night.
that, have a great evening to all the experts. Thank you very
Thank
much for
you.
joining and sparing your time.
Thank you so much. Thank you, sir.
Thank you. Good night.
Good night.
Night, sir.
Good night, sir. Bye-bye.
Yeah. Thank you so much, sir. So